everyone, my name is Alexandria Cronin and I'm a research scientist for the Department of Emergency Medicine at the University of California, San Diego. Today I'll be telling you about a project entitled COVID-19 Testing and Vaccination, Perceptions from Emergency Medicine Physicians. My co-authors are listed on the screen and the authors have no conflicts of interest to disclose. Just some brief information or background on this project. So as all of you know, emergency departments are a clinical setting where COVID-19 exposure or the risk of exposure is pretty high. On December 11th, 2020, the FDA allowed for the COVID-19 vaccination to be used officially under Emergency Use Authorization, and emergency department clinicians and staff were of the first groups of individuals to be slated for vaccination. Therefore, it's important to understand the perceptions of those ED physicians in regard to testing and vaccination. The goal of our project was to nationally assess physician sentiments pertaining to COVID-19 testing and vaccination, which we did by creating a prospective survey with 7 questions. And we worked with the Emergency Medicine Practice Research Network, or EMPRN, through ACEP to send out our survey to roughly 1,200 emergency department physicians nationally. The data we collected occurred between November 12th and December 17th, 2020. This is a list of our survey questions. So the first 2 questions really just asked how people had been tested for COVID-19 through either the non-antibody or antibody tests. The next question looked at whether or not someone would be willing to receive a COVID-19 vaccine, such as through a clinical trial or emergency use authorization. And the next questions were really just asking about willingness to receive regular testing and whether or not frontline healthcare workers should receive testing and by testing type. We had a total of 187 survey responses. I've broken them down kind of by age and gender here. So as you can see, we had a pretty good distribution of males and females. There were clearly more males than females. The youngest age, I believe, was 32, and the oldest age was 74. So that's why we use this age distribution. Here, this was just something I put together in Tableau. So I just looked at like the regional distribution of the data. So in the West, we had 38 individuals. In the Midwest, we had 45. In the Northeast, we had 35. In the Southwest, we had 23. And in the Southeast, we had 46. So pretty good data distribution regionally. The first question, again, was really just asking the number of times people had been tested and by testing type. As you can see, the bulk majority of respondents actually had not been tested. And again, this was at the end of Q4 of 2020. So to me, it's interesting that because the bulk majority of individuals had not been tested by either testing type, that suggests that there may not have been regular testing or routine testing regimens at many institutions yet. And I know for our institution specifically, routine testing started to take place in January and is still ongoing now for non-vaccinated individuals. Again, just reiterating that point again too, that there were very few people who had been tested 4 to 6 times or 7 or more times by either testing type. We also asked emergency department physicians about their willingness to receive regular testing, and there was an overwhelming majority that said that they strongly agreed that they would be willing to receive regular antibody testing. But this is interesting because if you ask them about whether or not frontline healthcare workers should receive regular testing, a lot of people were kind of just neutral. I mean, there were definitely more people who said that they agreed than disagreed, but the bulk majority of responses, as you can see, were kind of indifferent to regular testing. The other question that we asked our survey respondents was about their willingness to receive the COVID-19 vaccine and by which method, so by clinical trial or under emergency use authorization. And as you can see, a lot of people strongly agreed that they would receive the vaccine under emergency use authorization. And then again, overall, there were definitely more people that agreed to receive the vaccine by either method than those who disagreed. But I think it's interesting that between the people who were neutral or disagreed to whatever extent, they made up about 1/3 of the responses in the data. So it's interesting to me that 1/3 of this population that we surveyed was not willing to become vaccinated or was not sure about becoming vaccinated at the end of Q4 of last year. So if we went and revisited this now, it'd be interesting to see how that might have changed given increased vaccination efforts and the constantly evolving information that we have about the vaccine. Limitations and conclusions. So data were gathered again in Q4 of 2020 and may not reflect current trends. In November and December, there weren't many respondents who had received formal testing, suggesting that many did not have regular testing at their institution, but that's probably changed a lot by now. Physician respondents were willing to receive regular testing, but were neutral when asked if frontline healthcare workers should receive regular testing of either type. Many physician respondents were willing to receive the vaccine under a clinical trial or emergency use authorization, but roughly 1/3 were either neutral or in disagreement with receiving the vaccine. Again, my name is Alexandria Cronin. I'm a research scientist for the Department of Emergency Medicine at the University of California, San Diego. My email address is aocronin@health.ucsd.edu if I can answer any questions. And thank you.
Hello, everyone. My name is Sarah Ring-Gibbs, and I will be presenting our research, which is titled Delaying Blood Cultures Reduces Bacterial Growth in Septic Emergency Department Patients. So first and foremost, I have no financial interest, conflicts of interest to relate. And let's get into it. So this topic in general is not complete without a discussion of the Surviving Sepsis Campaign and their guidelines. So particularly in the Surviving Sepsis Campaign guidelines, they recommend that blood cultures be drawn prior to antibiotics being administered. However, with the caveat that that should not delay an antibiotic administration by over 45 minutes. The goal of this is to select an appropriate antibiotic, especially upstairs, and to identify the one that that microorganism could potentially be susceptible to. But with any meaningful guideline, it's important to kind of evaluate the data behind it and evaluate whether or not that is a theoretical ideal or whether or not it clinically and statistically bores out, which was our attempt to do so. In general, there has been quite a bit of literature to support some of this, but we wanted to dive a bit further. So some of the literature that did guide our questioning. So first and foremost, we have the top study blood culture results before and after antimicrobial administration in patients with severe manifestations of sepsis. So basically they found that collection of blood cultures following antibiotic administration has been shown to reduce rates of positivity in comparison to pre-antibiotic collection in a prospective cohort study. Also, kind of as we go down this list here, there have been studies that have shown longer hospital length of stay and increased mortality in patients who came through the emergency department who had blood cultures drawn following first antibiotic dose. So there are some negative potential repercussions to antibiotic dose given first prior to blood cultures being drawn. And finally, the use of appropriate antibiotic has been associated with reduced mortality outcomes in patients with sepsis, severe sepsis, and septic shock, as in this last study. So it is quite important that the correct antibiotic that microorganisms are susceptible to is drawn in terms of clinical outcomes. But what we particularly wanted to know was how frequently do blood cultures collected on septic patients in the emergency department demonstrate positive growth based on level of sepsis severity and timing of antibiotic administration. So our study design, we were a retrospective review of a single center. It was a large urban ED in New York City, and the time frame was January to December of 2019, chosen specifically so that we could avoid some of the confounding data that would result from the COVID-19 pandemic, which hit New York City in about March of 2020. Inclusion criteria. So our patients were greater than 18 years old, and they had clinical sepsis as defined by a combination of 2 or more SIRS criteria with a presumed infectious source by their treating team. We then took the included data and performed logistic regression on it, and that was used to evaluate the relationship between sepsis severity and antibiotic administration timing with regards to culture positivity rates. So our results, overall, we identified 1,335 patients who presented with sepsis. 813 of those, or 60.9%, also met criteria for severe sepsis, which we defined by CMS guidelines as having 2 manifestations of SIRS criteria, but also with signs of organ dysfunction, which could include a lactate greater than 2. 127 patients, meanwhile, or 9.5% of them, had septic shock. And that was defined as again, the CMS guidelines of having persistent hypotension 1 hour after crystalloids or having a lactate greater than 4. In our sample, 758 cultures, which is 56.7 of them, were drawn prior to antibiotic administration. And of overall 1,339 cultures drawn, 225 of them, or 16.8%, were positive for bacterial growth. Overall, we found that positive blood cultures were more frequent in septic shock compared to sepsis or severe sepsis. And so when you kind of broke that down, you can look at the pie chart. At 39%, we determined that number of people had a bacteremia, otherwise unspecified. 33% with positive cultures had septic shock. 11% were found to be in sepsis in general, and then 17% were severe sepsis. So our p-value on that was less than 0.001, achieving statistical significance. And then finally, after controlling for disease severity, 18.2% of blood cultures collected before antibiotic administration had positive growth versus 15.1% collected afterward had positive growth with a p-value of 0.023. So our take to the ED points, blood culture growth helps treat septic patients upstairs, particularly in multi-drug resistant and atypical microorganisms. Blood cultures were more likely to grow in more severe disease states, i.e. septic shock or severe sepsis. And finally, as consistent with surviving sepsis guidelines, culture collection prior to antibiotics will more likely result in culture growth. All right. Thank you guys. Take care.
Hello, everyone. My name is Dr. James Ford, and I'm giving this presentation on behalf of myself and my colleagues here at UC Davis Health. Today, I'd like to talk to you about the utility of asymptomatic COVID-19 screening in adults in the emergency department. We, the authors, have nothing to disclose. High rates of asymptomatic infections with COVID-19 have been reported, with one study demonstrating that as many as 56% of patients with COVID-19 were in fact asymptomatic. Asymptomatic transmission is known to be responsible for a high percentage of new infections, with one study demonstrating that as many as 44% of patients became infected after exposure to an asymptomatic but known to be positive individual. A previous study from our group demonstrated that asymptomatic testing was of low yield when conducting testing in a low prevalence region. In this study, we aim to describe the use of an asymptomatic COVID-19 testing protocol in adult patients in the emergency department. We conducted a retrospective cohort study at a single tertiary academic emergency department in Northern California. We screened adults over the age of 18 who were tested for COVID-19 under the asymptomatic protocol between the months of May and October 2021. The COVID-19 test we used was a reverse polymerase chain reaction of SARS-CoV-2 RNA using nasopharyngeal swabbing. The primary outcome was positive COVID-19 testing, and patients that had positive tests underwent further data abstraction. County level data was used to estimate daily COVID-19 cases per 100,000 individuals in the region, and we present our data as simple descriptive statistics. A total of 7,408 patients were screened during the study period, with a mean age of 54 years and a standard deviation of 19 years. 78 total patients were found to be COVID-19 positive, representing about 1.1% of the study cohort. However, upon further assessment, 32 of these patients were actually found to have signs or symptoms of COVID-19. 48 patients underwent infectious disease consultation, and 13 patients were treated for COVID-19 with things such as oxygen, remdesivir, and dexamethasone. Here is a graph demonstrating or comparing the local rate, the Sacramento COVID-19 case rate per 100,000 to our local institutional asymptomatic COVID-19 rate in our adult patients. We see that the local community rate ranged from 4 to 25.74 cases per 100,000 during the study period, and no positives were found that were asymptomatic when the rate was less than 4 cases per 100,000. So in summary, COVID-19 testing is of low yield and the daily community rate is less than 4 cases per 100,000 individuals. And about 40%, about half of our COVID-19 positives had signs or symptoms attributed to COVID-19, suggesting that the actual rate of asymptomatic infection was lower than the 1.1% we report. So in summary, ED physicians should assess for COVID-19 signs and symptoms even when patients present for other indications other than shortness of breath or things that could be plausibly related to COVID-19. Here's a list of my references. Thank you for your time today.
Hello, my name is Brian Rice, and I am a clinical assistant professor in the Department of Emergency Medicine at Stanford University, and I'm the research director for Global Emergency Care, a non-governmental organization that is US and Ugandan based that trains non-physicians to deliver unsupervised emergency care in rural Uganda, which is the setting for this abstract that I'm presenting here. It looks at a decade of data from 2010 to 2019 with the experience of sepsis in an emergency unit there. And let's get right into it. So on behalf of my fellow authors, we have no financial disclosures, no funding was received, and there are no conflicts of interest. What do we know about sepsis globally before this study that really drove us to do this study? We know that it accounts for about 1 in 5 deaths globally, and that by far the highest burden, as well as the lowest quality data, come from low middle income countries, especially those within sub-Saharan Africa, like Uganda, and that the limited data we do have really is national estimates, mathematical models, and there's a huge dearth of patient level data with almost zero data coming from emergency units, as emergency medicine is really in its infancy in sub-Saharan Africa. And also a crucial point that optimal management is still unclear for sepsis. A 2011 landmark paper showed that there was an increase and not a decrease in mortality when children with severe infections were given fluid boluses, and its applicability to adult sepsis is not yet clear, and the guidelines that do exist, it is unclear whether or not they increase or decrease mortality. So what does this study add? It is the single largest study of sepsis outcomes ever published. It has actually more patients in it than the other studies all combined. Describes a decade of data, giving us some longitudinal information about how Uganda and Ugandan sepsis changes over time. It shows that the quality of care as defined by meeting existing guidelines improved by the non-physician clinicians over time. The mortality also increased, and that retrospective analysis to try to control for these various factors really ended up being confounding by indication, really ended up limiting our what we saw. So more about that later. All right, this is almost a decade of my life, so I want everyone to look at my flow diagram, cheer quietly at your virtual computers. We ended up with a whole bunch of patients with suspected infections, and a quite large number of them that met sepsis criteria, which we used QSOFA for this. It's validated in global settings. QSOFA is the quick sequential sepsis-related organ failure assessment with 1 point each given for tachypnea, altered mentation, and hypotension. What did we see? There was a slight increase, pretty stable number of patients per year seen in this ED, about 3,300. There's a slight downtrend in the number of patients with suspected infections seen each year, but what we really see is this huge reduction in the incidence of sepsis and this almost complete disappearance of malarial sepsis. That what once was just over 4% of every patient that walked through the door, and every adult patient that walked through the door in this ED had malarial sepsis, not just malaria. That rate was down to less than 0.1% over a decade, and showed the profound effect that community-based interventions had on what we saw in the ED. We really do hope that the Ugandan Ministry of Health is excited to see this data as we are. What else did we see? We saw that there was an increase over time of how sick the patients were, as defined by a higher QSOFA score. Again, the profound decrease in malaria, increase in elderly patients, and some stuff stayed the same. The proportion of patients with hypertension remained relatively stable. This is probably the thing that we're most proud of with this study as a training NGO, that there was a clear increase in the quality of care as defined by meeting sepsis guidelines in Uganda, of giving the proportion of patients that received fluids and antibiotics, those that received antibiotics, those that received just fluids, and then a real reduction in the number of patients that received neither in the ED. trying to control for all these various changes that I just described, we developed a logistic regression model, which, God, I would love to talk about all the methodologic details, not enough time. It is well calibrated. The things that were expected to increase or decrease mortality were. That produced coefficients, which we then plotted over time, and were able to see that predicted mortality as well as observed mortality both did in fact increase over time. This brings us to our most unexpected finding. At the end of all this, we added the quality of care, fluids, antibiotics, or both into the model. And what we found was that all interventions were associated with an increased relative risk of death. Fluids, antibiotics, as well as fluids and antibiotics, which clinically and statistically significant. And so this is really a falsification test, the use of the antibiotics. It showed that first principles say that the sickest patients get the most things done for them, the most resuscitations delivered to them, and that ultimately that this model was unable to control for that confounding, and that because antibiotics were seen to increase mortality, that the finding that fluids increase mortality was felt just to be confounding by indication. And what that really does is that says that retrospective analysis is inadequate to define optimal care, and that we really do need high quality RCTs going forward.
Good afternoon. My name is Kieran Farrier. I would like to present our abstract entitled Latent Tuberculosis Infection Screening in an Urban Emergency Department in the United States. I would like to thank my co-authors, Drs. Ancona and Lyons with the Department of Emergency Medicine at University of Cincinnati, as well as Dr. Huaman in the Division of Infectious Disease, Department of Internal Medicine, University of Cincinnati. The authors have no relevant disclosures. So latent tuberculosis infection is a detectable immune response to Mycobacterium tuberculosis in the absence of active TB symptoms. Approximately 12.4 million people in the United States have latent tuberculosis infection. High-risk populations include first-generation immigrants, as well as those who are currently or previously incarcerated or homeless. First-generation immigrants represent approximately 73% of those with latent tuberculosis infection in the United States. Latent TB can progress to active tuberculosis. Patients with latent TB can be treated, however, to prevent progression to active tuberculosis. This is one of the pillars that is being used to help to end the TB epidemic, both in the US and worldwide. Emergency departments have successfully screened for other infectious diseases, such as HIV, hepatitis, and COVID, but have not engaged in any latent TB infection screening. So at University of Cincinnati, we conducted a pilot screening program. We used a convenient sample of first-generation immigrants who presented to our emergency department. The goal was to look at percent positivity as well as overall feasibility of the program. We identified first-generation immigrants in several different ways. This is a screenshot of our electronic health record. In the top right corner, you can see preferred language. This was one of the ways our staff identified those patients who were first-generation immigrants. They also looked in the triage note for any foreign travel or if an interpreter was needed during triage. So our study question was, in our pilot screening program, what proportion of tested patients were positive for latent tuberculosis infection? This was a cross-sectional review of this program's database in a single urban academic trauma center. Program staff identified first-generation immigrants without a known history of latent TB or prior TB treatment. Patients were tested using QuantiFERON Gold Plus. The primary outcome was the proportion of tested patients newly diagnosed with latent tuberculosis infection. The secondary outcome was the number of patients who initiated latent TB treatment. Table 1 summarizes the demographic characteristics of the tested patients. 27 patients were approached, 23 were identified as eligible, and 22 were ultimately tested. The median age was 32.5 years old, and approximately 59% of patients were male. Program staff were advised to identify first-generation immigrants in these specific regions. These regions are known to have a higher proportion of patients who have TB, and TB is more endemic in these regions. Here's a stacked bar graph identifying patients within this program based on country or region of origin. Latin America was the most common. Approximately 9 patients were identified from Africa and 1 from Asia. Table 2 highlights our primary and secondary outcomes. Of the 22 patients that were tested, 3 were positive for latent tuberculosis infection with a positivity rate of 13.6, and then 2 out of the 3 patients who tested positive initiated treatment. Patients who were identified as positive were linked to our county's tuberculosis clinic in order to initiate treatment. So in conclusion, prevalence of latent tuberculosis among at-risk patients is significant in our emergency department. Screening at-risk patients and linking them to public health treatment services is feasible. In addition, EDs can engage in TB elimination efforts in the United States through this or similar screening programs. Next steps. So more work is needed on screening approach, specifically teasing out risk targeted versus universal screening. Other considerations include operational workflows, such as the incorporation of the electronic health record, as well as policy considerations. For us, next steps include expanding our program to include other at-risk groups, such as those who are currently or previously incarcerated or homeless. I thank you very much for your time. I'm happy to entertain any questions at this time.
Hello, everyone. I'm Nate Scott from Hennepin Healthcare, and I'm happy to be with you today. On behalf of myself and my co-investigators, I'm excited to talk with you about our work in clinician diagnostic gestalt of sepsis during resuscitation. I have no financial conflicts of interest to disclose. As we're aware, current quality measures, such as the CMS SEP1 measure, call for the rapid diagnosis and treatment of sepsis in the emergency setting. However, the process and timing in which clinicians develop a diagnosis of sepsis remains poorly understood. The objectives with our study are to measure the very early clinician gestalt of sepsis among critically ill medical patients and look at the evolution of clinician gestalt during resuscitation as additional data becomes more available. We've set this up as an ongoing prospective observational cross-sectional study taking place at a single urban emergency department in the United States. Adults triaged to a defined critical care area were included in the study, and exclusion criteria included cardiac arrest, active labor, trauma requiring a trauma team activation, cardiac catheterization, or a stroke team activation. This figure helps show how patients progress through the study. Time 0 was considered to be when the patient arrived in the emergency department. At 15 minutes after arrival and at 60 minutes after arrival, assessments were completed. These assessments consisted of a trained research coordinator asking the treating physician, what is the likelihood that this patient had sepsis? Responses were recorded from 0 to 100 on a visual analog scale. Again, this took place both at 15 minutes and at 60 minutes. The diagnosis of sepsis was defined using ICD-10 codes as specified by the CMS Sepsis Core Measure, also known as SEP1. These were obtained from administrative data through the electronic health record. Visual analog scale scores at the 2 time points were compared by sepsis diagnosis or not using Wilcoxon rank sum tests. So far in this study, we've screened 919 patients. Of those, 256 have met eligibility. Of those, 246 had a 15-minute assessment completed, and of those, 183 went on to have a 60-minute assessment completed. terms of our results, for all patients, the median VAS score at 15 minutes was 17 and was approximately the same. It was 18 at 60 minutes. Patients with sepsis comprised 6.3% of the total patients in the study. For those patients, the median VAS score was 70 at 15 minutes and increased slightly to 87 at 60 minutes. Patients without sepsis made up the remaining 93.7% of the patients in the study. For those, the VAS score at 15 minutes was 14 and slightly lower at 12 at 60 minutes. Comparing the VAS scores of patients with sepsis versus those without sepsis at 15 minutes, we see that the score for sepsis patients is much higher, 70 versus 14, and that difference is statistically significant. At 60 minutes, the VAS score for patients with sepsis was 87 compared to those without sepsis was 12. That difference was also statistically significant. Some other results of note: 20% of patients with sepsis had an initial clinician gestalt of less than 50. And interestingly, 10% of patients without a sepsis diagnosis had an initial gestalt of greater than 50. Some limitations to the study include that to date, there's a low number of patients with a diagnosis of sepsis. There's also multiple ways to define sepsis. We chose a way that was aligned with the CMS SEP1 core measure. However, there are other ways to do this as well. And our generalizability is limited to critically ill medical patients based on who we enrolled in this study. In conclusion, clinician gestalt for sepsis in the emergency setting develops rapidly within the first 15 minutes of evaluation and is accurate, although not perfectly so. Gestalt continues to marginally improve within the first hour, though to date, this difference is not statistically significant, in part due to lower enrollment. These findings have significance for what can be reasonably expected of clinicians in quality measurement programs. In terms of future directions for this work, we are early on in this study and have a planned total enrollment of 2,500 patients, noting that to date, we have about 250. These other questions are also suggested by these results. What are the primary influences of clinician gestalt, and how does testing influence clinician gestalt? Also, does accuracy of gestalt vary in different subgroups? Thank you for your time and the opportunity. I'd be happy to take any questions.
Hey everyone, thank you for this opportunity by the SAM for this oral presentation. My name is Alexis Gode, and I'm a third-year medical student at LSU Shreveport, and I'll be discussing our work on the COVID-19 experience in Northwest Louisiana from the EM perspective. I have nothing to disclose. As you may know, SARS-CoV-2 is the novel coronavirus responsible for the current and ongoing pandemic. The US has been one of the countries most significantly impacted by COVID-19 and currently leads the world in both cumulative incidence and total number of deaths, with about 30.5 million cases and about 550,000 total deaths as of April 1st. Amongst all 50 states in the nation, Louisiana is one of the leading states in overall case and death rate per 100,000 people. As of April 1st, we've had about 444,000 total cases and about 10,000 total deaths. In Northwest Louisiana, which is this region over here, we've had about 60,000 total cases and 1,500 deaths. This left side represents COVID-19 incidents, and this right side represents mortality. Our study was a dual center retrospective observational cohort study, which was done at 2 Ochsner hospitals, including LSU Shreveport and LSU Monroe ED. The study was a ratchet study, which is revealing associations to COVID-19 hospitalizations, evaluation, and treatment. Our inclusion criteria were adult patients who presented to LSU Shreveport and Monroe and were COVID-19 positive between March 1st, 2020 and March 10th, 2021. We gathered data through our health record system, which is EPIC, and then recorded and analyzed the data through Excel and GraphPad Prism. Our data fields were patient demographics, comorbidities, presenting complaints, and clinical outcomes. In our study, the majority of our patients with COVID-19 were females and were between the ages of 46 to 59. The vast majority of our patients with COVID-19 were African American. The most common underlying comorbid condition was hypertension, followed by cardiovascular disease, and then obesity. The most common presenting complaint to the ED was shortness of breath, followed by fever and chills, and then cough. In our study, although most of COVID-19 patients were female, males made up a larger percentage of the total deaths and had an overall higher mortality rate when compared to females. The highest percentage of deaths in our study population were between the ages of 60 to 74. However, the age-specific mortality rate was highest among those greater than 75. And as you can see in the graph on this right side, there's an increased trend in mortality with increasing age. Out of the total 156 patients that died from COVID-19, 71% were African American and only 26% were Caucasian. Our data indicates that although African Americans had an increased incidence of COVID-19 and made up the majority of the total number of deaths, there was no significant difference in race-specific mortality rate. This can be attributed to the large African American population that lives in our region and comes to our hospital. 80 to 90% of all the patients who died from COVID-19 had underlying cardiovascular disease or hypertension. Obesity was also a common predisposing risk factor associated with increased mortality, especially in the younger age groups. 80% of patients between age 18 and 30 who died were either overweight or obese. The vast majority of our patients who died from COVID-19 initially presented to the ED with shortness of breath. Neurological symptoms and fever and chills were the next most common initial presentation in those who died. In summary, in our study of COVID-19 patients in Northwest Louisiana, the majority of them were females, but males had a higher mortality rate. Mortality was increased with advancing age, and the highest incidence and total number of deaths were seen in African American patients. However, race-specific mortality was similar to Caucasians. Cardiovascular disease, hypertension, and obesity were the most common underlying comorbidities and were also associated with an increased mortality rate. Shortness of breath, fever, chills, and cough were the most common presenting ED complaints. Death count was highest among those presenting with shortness of breath, neuro symptoms, and fever and chills. Thank you again, and I would like to give acknowledgement to Dr. Janad Ansari, Jessica Hicks, and Dr. Avery Callahan.
Hello everyone, my name is Joshua Briscoe, an EM attending physician and full-time faculty member at Orlando Health. Thank you for joining me as I discuss the pilot program we launched at our academic tertiary referral hospital. We will take the next few minutes to review our abstract titled, Using Telephone Communication in the ED to Improve the Patient Experience, the Outreach Pilot Study. For this program, our institution configured a technology platform in an effort to enhance our patients' experiences during their ED stay. It is our belief that as medicine becomes more digitized, our customers are appropriately expecting the same convenience and experience as they do in the consumer world. With that in mind, we sought out to evaluate the feasibility of using direct communication through SMS to communicate with patients about their needs and provide updates about their medical care while they're in the emergency department. We performed a cross-sectional study for 22 days in December of 2020, including patients with acuity levels 2 through 4. We collected data on total census, number of messages, and unique patients, and tracked the questionnaires submitted and their responses to such forms. 4,720 patients were eligible for the study, 90% of the total census for this time period. We were successful in 81% of outreaches. 10% of the messages were sent to a landline number inappropriately entered into the mobile number data field into the EHR, and 8% of messages were not sent because there was a non-functioning phone number on file. Only 1% of patients opted out of receiving such messages. When we examine the questionnaire responses, the majority of patients, about 62%, requested a food or beverage. 40% of patients requested a comfort item for themselves or a family member, such as a pillow or blanket. And approximately 30% of patients had questions for their care team, meaning the nurse or the provider taking care of them. In conclusion, we were pleased that the majority of our patients decided to participate with such a low opt-out rate of 1%. This and the other metrics highlight the desire of better, more efficient, and convenient digital communication, even in the hectic ED environment. The program successfully established communication in 90% of cases, and over 70% of patients found the messages helpful, requesting that they continue for subsequent visits. As we look towards continuing the program and expanding across other campuses of our health system, we believe this will be a successful and repeatable process. Thank you again for taking the time today. Take care.